And we are really excited for this panel. And the idea came from my own experiences having a physical disability called right hemiplegia, which is a form of cerebral palsy, and as a result of a stroke I had before birth. So before we get started introducing the panelists, I just wanted to go over a few things. We do have live closed captions available for all participants, so hopefully that is showing up on your screen if you choose to utilize them. And we ask that you use the chat function to ask any questions that may come to mind during the discussion. And you can feel free to pop questions in the chat at any point throughout the panel. So I am going to share my screen real quick, and we will introduce all of our panelists. So first up, we have Dr. Catherine Sorenson. She's an assistant clinical professor and academic fieldwork coordinator at the University of North Carolina at Chapel Hill. And she's also a certified ADA specialist and works with UNC's Disability Services Office to help provide accommodations and adaptations for students on campus. As a person who uses a wheelchair, she has a passion for ensuring that other people with disabilities have access to the same meaningful activities as everyone else. Next up, we have Dr. Diana Cejas. She is a child neurologist whose clinical work and research focuses on improving care delivery and health outcomes for youth with neurodevelopmental disabilities. Since surviving cancer and a stroke during residency, Dr. Stahas has devoted much of her career to patient advocacy and improving communication between healthcare providers and the disability community, particularly for young disabled patients of color. Next, we have Molly Morris Quinley. She is proudly neurodivergent and works with Neurodiversity Empowerment Services as an agency and a co-director and psychotherapist. Molly is an alumni of UNC Chapel Hill's School of Social Work. She identifies as both autistic and an ADHDer, and she's passionate about advocating for disability justice in her local community and in the world at large. Next, we have Dr. Christopher Lunsford, who specializes in pediatric rehabilitation medicine. He is the co-director of the Cerebral Palsy and Related Conditions Clinic at Duke Health, and his research includes cerebral palsy and spinal cord injury interventions, disability advocacy, virtual reality assisted therapy, and rehabilitation care coordination. He identifies as partially deaf and leads an informal Zoom group called Disability Consciousness in Healthcare for scholarly discussions and mentorship at Duke. Lastly, we have Dr. Lindsay Saunders, who received her doctorate in physical therapy from the University of North Carolina at Chapel Hill. Dr. Saunders has pursued advanced training in pelvic health throughout the Herman and Wallace Pelvic Health Rehabilitation Institute, including pediatric bladder and bowel dysfunction. Dr. Saunders lives with cerebral palsy, and she is unable to make it tonight due to 2 sick babies at home. So if you have any specific questions, Laura will put my email in the chat, and you can feel free to direct them towards me and I'll pass them along to her. So those are all of our panelists. So let's just go ahead and jump right into the panel. And if anyone has questions throughout the night, just a reminder, feel free to put them in the chat and we'll bring them up throughout the discussion. So the first question we have for all of the panelists, and you should be able to identify the panelists by their credentials listed after their name. And the first question we have is, what is your experience when you were a student with a disability? And any of you can feel free to unmute whenever you're comfortable. We don't have a specific order.
Always so hard to know who goes first, and I always have learned to just jump right in, and it's actually related to my disability, so I might as well jump right in. I am Christopher Lunsford, as you said. Thank you for that wonderful introduction. And I am partially deaf. I used to say hearing impaired, and while I don't have a problem with that language. I've gotten some feedback that other people might, and I am happy to be an ally in using language that is more inclusive. And as a partially deaf person, when I was a student, it was really interesting because I didn't have a lot of insight into how much it affects my life more than the obvious that I have a speech impediment. And but that's also why I was never really, as a human spirit person, I had no problem with the extroverted skill of speaking. And so always just jumping right in, being the first to speak up, trying to be the good parts of like a Hermione Granger kind of thing, where I just keep things going, make sure people are inviting. I also, though, have had to work against that to be able to really focus on my listening as a physician and to make sure that I'm not just talking at my patient. And then with my disability, I had trouble with finding a stethoscope. I had trouble with finding rooms that had horrible acoustics where my learning was just not happening. And I don't like highlight it, but I also identify as neurodivergent with extreme attention deficit. And so once I am bored with the situation or not hearing and it's not good for me, I am tuned out and doing my own thing, and I'll just go study it later. So if those are some of my experiences.
Thank you for sharing and also highlighting the interplay of multiple disabilities.
I can go next. So I, as you mentioned in my introduction, am autistic and an ADHDer. And I also forgot to mention in my intro stuff, I also suffer from chronic migraines and chronic pain, not associated migraines. So a lot of related disabilities that affected me all in very different ways as a student, that really created an atmosphere of challenge around not just like how to do the work or how to advocate for myself within that, but also just managing, can I attend class today? Is the sensory stimuli, are they like the overhead lights going to be too much? Are people going to be annoyed if I wear sunglasses or headphones or whatever I need? I also would often crochet in classes to help maintain my attention, to have that just little extra stimuli going that could keep me focused on the lectures. And it was really look or do not appear. I don't have visible disabilities. And so unless a professor could get moments where trying to ask for accommodations was really frowned upon or kind of seen as, why would you need help? And so that was something I definitely struggled with a lot throughout my academic career.
Thank you for sharing. I'm sorry, I missed part of it. I'm not sure if it was my internet or not. It might have been mine, but I appreciate you sharing all of that and the unique aspects in your situation.
I'll go next. That's cool. I'm Katie, professor of occupational therapy and occupational science and clinical education coordinator at the University of North Carolina in Chapel Hill here. See a lot of my students on here. Hey guys, it's cool you're not studying. Totally, it's fine because you're here listening to me. So here's things I'm sharing right now is Katie. I have many hats, I feel like, in the division. So I'm talking as Katie right now. And for those of you who have not met me, I use a wheelchair. I feel like I always need to disclose that because I make a lot of wheelchair jokes. And I don't want you to think I'm being a jerk if I do that. Like, it's legit. I'm totally allowed to do that because I actually use a wheelchair. But I was born with osteogenesis imperfecta, which, if you're not familiar with that, is also known as brittle bone disease, which I don't love calling it that because people think that they can't high five or hug me, which are huge parts of my identity and just loving, interacting with people in that way. But I used crutches my whole life for the most part, went out to grad school in California, and I was on crutches when I entered OT school and really wanted to go work in a hospital in an acute pediatric setting. My dream was to go back to my hospital that I went to in New York growing up and work like alongside my doctor as his occupational therapist. Fun fact, I always thought that occupational therapy was physical therapy in Spanish because it was occupational physical therapy, and then occupational therapy was written under it. So I just thought it was physical therapy in Spanish. So I didn't know Spanish, but when I realized that occupational therapy was its own thing, I'm like, oh, I could totally do that. But that was my dream, was to go back to Columbia Presbyterian and work alongside my doctor with his team. And so I went out to California, and halfway through grad school, I fell and I broke my hip really badly. And I ended up in my wheelchair full time, and it changed everything for me. I had a broken hip the entire last year of grad school, and doing both my clinical rotations in a hip brace with a broken hip the whole time. And it was really hard. It was hard to find a placement. I mean, my education field, clinical education coordinator should have like a lifetime achievement award just for finding me a place. But I wish someone had sat down with me and been like, look, you can still be an OT. And I think I'm still a great OT, but realistically, there are things that I can't do, and that's sad and it sucks, but it's okay. It doesn't mean that I can't be an OT. It just means, like, as someone with a disability, I've also, I am an OT. I've been a patient. I've been in the ICU on a ventilator with an unstable cervical neck. And I wouldn't want someone with OI to be there to help me get out of bed the first thing after surgery. And I love people with OI, like those are my people. But I mean, realistically, like I'd want, Michael Jordan to come. And I mean, for a lot of reasons, I would love Michael Jordan to come to my bedside in the ICU. But and also now as a clinical education coordinator, like I want to set my students up for success. And so just being able to make sure I, sit down with people, like, is just something I have a lot of passion for. And so I wish someone had been able to sit down and just really sit down and help me set up for success. Because I feel like when I graduated, I kind of fell off a cliff, and I just was not prepared for how hard and challenging it was going to be as a healthcare provider using a wheelchair. I was not able to get a job ever doing acute peds because no one would hire me because I couldn't transfer people. And it was devastating and emotionally challenging, and I had to go to therapy for it and just really grieve a lot of things. And I found my niche now, but it took a while to kind of find myself and just find myself in the profession. And so I just wish there was more education and discussion about that and preparation for students with disabilities in healthcare, and it's kind of setting them up for success in the beginning, especially. And I'm speaking as someone with a major physical disability specifically.
Thank you for sharing, Katie. And I'm glad you're my fieldwork coordinator, where we can relate on that level in some sense.
So I guess that leaves me. Hello, my name is Diana Cejas. My pronouns are she, her, hers, and thank you for that introduction. I have the window open, so I really hope you can't hear neither my noisy neighbors nor the geese flock that's outside the door. Anyway, a lot that other people have talked about really is resonating with me. So I, in addition to being a cancer survivor and stroke survivor, I've had migraine since childhood. And when I think about my training with medical school in particular, the first thing that comes to mind is like, well, I didn't really have any accommodations in med school. But, as I've had time to kind of think about things, and especially since my illness, I think about the fact that it was more that I tried to hide my chronic illness when I was in medical school, because it's never seen as a good thing to need accommodations, to need help, to ask for certain things. I had other friends in med school who had learning disabilities and other kinds of chronic illnesses, and I saw how many hoops they had to jump through just to be able to get basic accommodations. So I remember thinking, well, I have my migraines, that's just the thing that I'm dealing with. I put my sunglasses on, I would be laying down on the couch trying to read and concentrate on my notes. And I guess I got through it, but I didn't think that it was okay for me to ask for help or accommodations. And even when I first got my cancer diagnosis, even then I kind of tried to keep some things to pretty close to the vest. I think that there was a lot that I was trying to work through because I have a pretty long and complicated story. But to sum things up, it took 5 years before I got a correct diagnosis of my cancer. The whole time I first found the tumor when I was in my first year of medical school, and went to the doctor multiple times trying to get them to listen to me, to take it seriously, to see that something was going on. And I was always told that either it was nothing, it was just an infection that would go away, or that I was being a med student who was just kind of a hypochondriac. So I think that, you know, I was first through that whole diagnostic process, had a lot of issues with not knowing where I fit in the healthcare system, because I didn't trust what some of the doctors were telling me, but at the same time, these were people I was supposed to look up to. These were my role models. These were, in certain cases, my attendings. So I had to work through a lot of that. And then when I knew about the tumor, found that out, told very few people, had a lot more issues around trust, because I would tell one person and suddenly my entire program knew really intimate details about me and my treatment plan. And then they would talk with residents who were actually in like my procedures and things. So it got really awkward. And I guess other things that I kind of learned was that healthcare providers are just not good with disability in general and don't seem to know what to do with it. And I knew that before, but I don't think I had the level of knowledge that I have now. Because I think when I first got sick and started kind of coming out, needing to go to like PT and OT and my speech therapies, and even getting my follow-up scans and labs and things for the cancer treatment, I kind of expected that they would just kind of understand, like, this is a protocol, this is what we do, this is how you're supposed to be treated. But it was like they had never even heard of these, like the fact that you have to go get like a scan or something. Like, it was just completely new and they had no idea what to do with it or me. And so sometimes it was like either people thought that I could do everything that I could do before, which is not true for me physically, or people thought that I could do absolutely nothing and probably shouldn't be in medicine. So it was a really rocky time for me, especially when I the first year to year and a half after my diagnosis. And things really got better. I think when I moved to a different program, because I completed the first part of my training and moved into my fellowship. And I think that part of the reason is because there were several doctors with disabilities and chronic illnesses in leadership in that program. So it completely changed things for me.
Well, thank you for sharing all that. And I'm glad you've had some positive experience to come from it all. Oh, Christopher, did you want to say something?
I was just gonna follow on to Diana's amazing comment, just to say that I had similar things in what I was seeing my patients go through, not that I personally went through. And it was, to me, it's that you have to put a name on so many things that you said, is that it's just ableism. It is out and out ableism. And so much of it is the innocuous discrimination or the innocuous negligence of not knowing your lived experience and not being able to meet you where you are. And for anyone else listening to all of us, I think that naming that elephant in the room is so important. That's one of the things that I've really taken on of trying to figure out how to be an advocate on anti-ableism, because people don't even think it's a problem. Like you said, you were labeled a hypochondriac med student, and once you're labeled, you're labeled. And it somehow floats with you. And it just really spoke to me that, for me at least, that's where the answer lies in some of that, is that we can't just rely on programs that have people with disabilities in leadership to have the change that we need. We have to get anti-ableism recognized.
Go ahead, Molly.
I absolutely want to echo that, and also echo some of Diana's experience with really keeping diagnoses close to your chest. I honestly, it wasn't until about a year ago that I started really being open with my autism diagnosis, particularly in the field of social work, wanting to be a psychotherapist. There's a lot of stigma around autism and expectations for autistic folks in general. But particularly when you're going into a field that people expect you to really grasp social nuance, to really understand, what people are saying, how they're communicating, and when in fact a strength that I brought was being able to communicate with other neurodivergent individuals really well. And particularly with my autistic clients, it's such a strength. And I was fortunate, particularly my last year of school, to have professors and field faculty, et cetera, who understood the strengths that I brought and were able to see that and understand those things. But keeping those diagnoses private was really important because there was a lot of fear of how that could impact all of my elements. And I apologize, my dog's wrestling his rope in the background. So.
Good. Yeah, no, I think that's a good point. And it definitely sounds like that's a common theme, that it's hard to balance when to disclose disabilities to make it be beneficial and when it may be harmful. So I'm seeing no questions in the chat. Panelists, you're doing a great job. Feel free to raise your hand and just respond to what others have said. But we'll go ahead and go to some of the other questions. Some of you might have already answered this in what you've said so far. But for those who might have some more to say, I'm wondering if your education covered the lived experience of people with disabilities and kind of how you saw it play out in your education, if at all.
I'm gonna go ahead and say no, absolutely it did not. And I can't speak for everybody, who went to medical school, but I feel like I can speak for a lot and say that, lived experience of people with disability was not something that we ever really talked about. We always talked about disability as pathology, or disability as something to be fixed. Even when we were talking about disabilities like that are you're born with, you're always going to have, you're always going to keep. So I actually did not really feel like I got my first disability education until I joined the LEND program. So I was a LEND trainee at where I trained in Chicago, University of Chicago. So I was part of the Illinois LEND. And actually LEND was not only where I feel like I got my first real true disability education. I felt like it was the first time that I was in a room with other disabled people talking about disability and learning about it from both a professional and a personal perspective. LEND is actually where I first said the word disabled with respect to myself. And I felt like I, got to the point where I was actually kind of understanding more about what lived experience is and how that can be something that we should be learning about on a kind of a professional level, if that makes sense. So I'm a LEND evangelist at this point, but I really don't feel like I would have gotten the level of education that I need to be able to work with my patients, even with my own lived experience, because I can't say that I have every disability. I work with a lot of patients who are autistic. I don't have that lived experience, so I need autistic people to teach me, or to learn from them and learn alongside them as well. If I really feel like I'm going to be a real, true advocate for my patients. But speaking from a medical education perspective, we really didn't talk about disability at all in med school or in my training, even when it came to the fact where I knew that I wanted to work with kids with disabilities. It was, again, focused on pathology, and maybe you learn how to refer somebody to OT, PT, speech, or something like that, but that's kind of the extent of it. We really didn't get the education unless we were out seeking it from other sources. And that's what I've started to do really since, is a lot of self-education on disability history and disability rights.
Thank you for sharing. And that is one way that we're similar. I'm also part of the LEND program, and I've greatly appreciated the ability to learn from others with a variety of disabilities. Katie, you have your hand raised.
Yeah, it's weird having I have my emoji hand raised, and then I was like, do I turn on my microphone or lower my hand first? Ironically, as through the occupational therapy program, we had a lived experience where I had to sit in a wheelchair for a day, and that was my first time ever sitting in a wheelchair. And it was then that I realized my living in a wheelchair is easier. So for me personally, it was a benefit because then I ended up buying a wheelchair thinking I would never need it. And I put it in my closet till I was 80 and then broke my hip 3 months later and thankfully had a wheelchair ready to go. So that worked out timing wise, ironically, but I got so irritated watching how many other people would sit in the wheelchair and then like just get out of it or just not take it seriously. And I was like, I wrote my paper about how other people weren't taking the experience seriously. And I see other programs on campus do it now. And I mean, I'm not a fan of it, if I'm being honest. And I'm not saying I'm not a fan of, people understanding the lived experience, but it's frustrating for me as someone in a wheelchair who needs to use the wheelchair accessible restroom, which, by the way, you are all welcome to use the wheelchair accessible restroom. However, please don't go in there and be like updating your Twitter and your Instagram. Like, just go in, do what you need to do, and then leave. That's when it bothers me. If you're like in there, like hanging out during your break, that's people always ask for that. You have my permission though, but people will go in there and they're, because they're doing their wheelchair experience for the day. And then like they're getting up and they're walking around. I'm like, let's just leave your wheelchair in the hall then if you're going to get up and walk around. Because I actually need that stall. And so, I mean, it's things like that that are kind of frustrating and defeating for me. And so when I teach, I try to bring in people who are just going to share their experience and talk about, the emotional roller coaster of how challenging things are. Today, I had someone who is the parent of a son with spinal muscular atrophy, and just what that experience was like learning about their son's diagnosis and all the challenges that come with that. And I think that is far more powerful than just having someone, sit in a wheelchair for a day. It benefited me personally, and the timing of it worked out because I ended up breaking my hip and needing a wheelchair 3 months later. But I think I'm literally the only person who actually benefited from sitting in a wheelchair for a day. So I am the exception to the rule, but I don't love that assignment personally. But in general, I am always offering my friends in the nursing school or other programs for me to come and just offer my own personal experience, because I don't think there's any better way for students to learn than to hear people with disabilities come and just say like, hey, sometimes this sucks. Like, let me talk to you about it. I'm like, just talk to you, I can keep it real.
I really appreciated that as a part of the OT program here at UNC. So if there are any other professors listening, I would definitely try and bring in more guest speakers, because it's definitely been invaluable to learn from all the guest speakers we've had.
I would add, that absolutely. The few times in my program, I had one professor who was very adamant about allowing her students to understand the lived experience of a variety of folks. And so brought in a singular disabled person with the excuse that was the only person she could find, whereas panels for other marginalities would bring in like 3 to 5 panelists. And I found that really interesting to say, you don't know anyone else with any disabilities. And not that I didn't appreciate the experience. The person who shared had very valuable information. But aside from that class that was part of the general curriculum, the classes that allowed me any interactions with folks with sharing their lived experiences with disabilities were either classes I intentionally sought out for myself that were like a disability policy class, the Lynn traineeship, and a class on autism. And within the general education class, we did have panels of like parents of children with disabilities. But it was always very focused on how the disabilities affected loved ones or caregivers, and not actually individuals for the most part, which I found really challenging as a disabled person in my classes, to say like, you're not getting this understanding, you're not grasping this lived experience. It's not just how it affects everyone around us, it's how it affects us as the individual who is disabled. And I am very appreciative for the classes I sought out that were very intentional about having folks share lived experiences as disabled individuals.
I'm glad to hear you've had positive experiences with that as well when the opportunity has been afforded to you. We did have a question in the chat. I think I lost it. It was based on Katie's experience. What experiences or education do you think would provide value in terms of a curriculum, I would assume?
I think it depends on the program I'm going to jump in. I mean, I'm looking and thinking through the lens of occupational therapy. And I think about teaching all day, every day. And then sometimes, I mean, all the time. But, you know, for me, I bring in other speakers first and foremost, and I share my own story. I mean, you know, it's hard to find that line between being a professor and sharing, but also like having a disability and sharing. You know, I've shared about my life, I've shared about my family, my struggles with my, you know, just growing up, and just, you know, dating, like all, you know, all the struggles, and just kind of how that my disability has impacted all the areas and aspects of my life. But I think it's way more impactful just having, you know, for me, I have a lot of friends who are practitioners, which I know whenever people find out that someone in a wheelchair has friends, that's inspiring. But, you know, making jokes like that. But, you know, a lot of my friends who are practitioners, just whenever they go out with me in public, they're like, wow, like I had no idea it was like this. And just being out with me, and, you know, I'm talking about wheelchair accessibility specifically, because that's, you know, a huge part of my lived experience. But you know, so having students learn more about ADA compliance and learn to see things differently and what's accessible and what's not accessible, and to show them pictures of things and to share my experience. Like, yeah, I went out this weekend and we couldn't go to this restaurant because my friends and I couldn't get in and there were no tables, and just to kind of open up people's eyes about those things, and to share like how it impacted me. I think for me, those are the strategies that I use, but I'm speaking as from my lived experience is largely because of wheelchair and how my wheelchair has impacted me in the community. But I try to share as much as I can and bring in other people as well. But you have to ask my students. I have to ask my students if it worked or not. So let me know, and I can get off Zoom early, and then you can give them an anonymous survey.
Well, from my perspective, it's worked so far. If anyone else would like to respond to that, feel free. But I will.
I'm just lighting up the chat with a bunch of answers to the questions.
Yes, thank you. Thank you for doing that. I appreciate it.
Keeping it very research-based, Christopher. I appreciate that. You're bringing in the scholarly.
Most of it is still people being published by colleagues with disabilities that are trying to bring this qualitative research into light that still moves the needle so people will listen to us, you know, so I try to keep up with it.
Yeah.
I've actually been doing some qualitative data. I didn't do it for 1 year, but I teach a class called Disability Help and Perspectives for Pediatrics, and I do a survey before the class, and then I do a survey at the end of class, and ask the students questions about how the class has impacted them, you know, feeling comfortable talking to people with disabilities and things like that. And I'm hoping to get enough data to show like bringing in people with disabilities help people feel more comfortable. And like, it is a great way to teach about disability experience and perspective. So I'll talk to you about it, Christopher, and we can write a scholarly paper on it.
Learning from folks with disabilities is absolutely the most important thing. One of my good friends uses a wheelchair, and I have learned so much from her about just accessibility, how to not be a complete jerk to individuals using a wheelchair. And just like hearing the things that people regularly do to her, like when she's with her husband, the people will talk to her husband face to face and like talk over her constantly. And just understanding those things have changed the way I've interacted with other, like particularly with my clients that I've interacted with who've used wheelchairs, that I like know some of the faux pas people regularly make. Not that I am sure I don't ever make mistakes, but that like I have just a very much more direct interaction, and just even just asking, hey, do you want the store open for you? Like, you know, asking that permission first to say, like, I acknowledge you may have a need, and I want to acknowledge your autonomy, that people don't seem to recognize. And those experiences allowed with one assignment that we had in our classes, in my disability policy class in particular, we had to go around our building and just notice anything that might not be accessible in our building. And with the coming into the end of the class and sharing, I had the longest list of things out of folks in my class. But we all had so many different unique things that were like, hey, yeah, this building is like horrible for all of these reasons. Here are the ways that it could technically be accessible. And the building passes ADA code. And it's really problematic in many ways too.
Thanks for sharing that assignment. That sounds like, yeah, I'm glad it definitely opened your eyes a bit. We have a question that is a great transition to the next section. We have a question that says, can you please discuss your transitions from being a student to a practitioner, and specifically a practitioner with a disability, and how that's played into it?
Mine did not go that well because there was no consideration for my disability. Pretty much accommodations offices don't have much to offer except for tell me to sit at the front of the class. And so then going into being a practitioner is, you know, I was used to rounding as a medical student, but then trying to go and be an intern and 24-hour shifts, sometimes 36 hours. And then knowing what that does to my nervous system when I have to try to listen for 36 hours, I think that was really hard. And as a general rule, since I'm guessing a lot of people here are younger, I think for me, because of the constant ableism I was hearing, I just kept pushing my disability under the rug, and did not know how hard I was working. And now that I am older, that, you know, doing 6 hours of listening is what I used to be able to do in 12. And so it really plays a big part of me just kind of feeling completely uncovered. So it was hard transition.
Thanks for sharing. Diana, did you?
Yeah, so I think I've had bumps at every transition, but I think that the bumps have started getting a little bit better now that I'm faculty, a lot better now that I'm faculty. And I'm not sure if the initial bumps were, you know, I was in residency, went from med school where I didn't have my diagnosis, got my diagnosis in the middle of residency. That was a disaster. Just because they did not know what to do with a resident who had had a critical illness at all, let alone one who was coming back to work and expected to. They made it so I completely destroyed the entire resident schedule, which I felt bad about at the time, but now I'm just like, well, what else was I supposed to do? But I had set everything up so that I was front loaded, so that I was planning to do all of my call months early, and then got my diagnosis, and that whole got switched around. So I had to transition back into, when I first went back to work, at first it was just to do didactics, and even that was very exhausting. But, you know, I stayed in the back of the room and tried to not let anybody notice me, even though everybody was always, you know, looking at me, I guess just waiting to see what would happen. I don't know if I can say that I got lucky, but we had a hurricane, because of course we did. And then I got some extra time off for the hurricane. But then when I transitioned back into going back to clinic, I first started working with my program directors in their clinic. since they were general pediatricians. And I think that that was nice because both of them actually had visited me at the hospital literally every day. So they kind of knew what was going on and also weren't jerks about it, which was nice. So if I said that I had to, I was not keeping up, or even if they just kind of noticed, I was okay to take breaks and things like that. But when I transitioned back to going back on the call schedule towards the end of the year, I was still going to PT and OT at that point, and still dealing with a lot of post-stroke fatigue, and it was just kind of a mess. Especially going back to when I was working in the ICU for the last couple of blocks of my third year. We worked with surgeons, and surgeons are not, no offense to any surgeons or anyone who loves a surgeon in this room or knows a surgeon, they're not the best at anything, just with interpersonal kind of stuff. So they were really just not seeming to understand why the resident couldn't stand up, for hours at a time on bedside rounds, or I got yelled at once because I wasn't talking loud enough. And I was like, I'm dysarthric. I can't make my voice any louder than it is right now. So that was a lot. And I dealt with a lot of ableism pretty much smack, from the beginning of my transition back to work, where people, I guess, complained because they thought I was taking off too much time because I would leave early to go get a PET scan and come back to work. So it was kind of a mess. But then when I transitioned to my next program, like I think I said, I think that it was a lot softer for me because I was in a neurology program. I was very upfront because I completely changed my own strategy. I was like, I'm coming in, I had this stroke, I have this stuff that's going on, you need to know about it. And when I asked for accommodations then, I think it was so much nicer because I literally was so scared to ask for things like dictation software and things of that nature because I had trouble typing. And I asked my program director, like right off the bat, and he was like, what kind do you want? Do you want the one that I use? I use one because I have X condition. And that was really refreshing. So, there were other attendings that were in that program that had various neurological conditions. So if I said I was having an issue, they said, okay, well, let's figure out what we need to do. If I said that I needed to go to PT, I mean, it was only so much accommodating that they were going to do. I still had to, do my overnight calls and things like that. But they were like, oh, you got PT today. We need to get you out of here so that you can go ahead and go like while you're still moderately coherent. There was one time when someone thought that they would have to call a stroke code on me because I was having some, fatigue kinds of symptoms. And that was funny for everybody. Not at the time, but it is now. But I think things definitely got better. Now that I'm faculty, I didn't like bust into the door and was like, hey, I had a stroke. But I think most of my colleagues know at this point about something, me having some chronic conditions. And everybody's been really lovely about it, which is really nice. So I think one of the luxuries now that I'm faculty is that I get to make up my own schedule. I purposefully took a position where I would have some clinical time, some teaching time, some research time, so that I don't have to have a full day of clinic every single day, because I just don't think that I'd be able to do it physically. Neither do I want to do it because I think I'd get run into the ground. So now I feel like, if anything, some of my colleagues are a little bit too protective of me. Like, it's okay, I can handle some of this stuff sometimes. Like, you don't have to worry about me needing to take naps in the middle of a workday. But still, it's been really a whole lot better now that I'm in a position to be able to kind of work my own schedule. But at the same time, I recognize that I am in a position of extreme privilege now, which is not going to be the case that a lot of people have, even in medicine.
Yeah. Well, thank you for sharing all of that. And you touched on something that I would hope that other panelists might want to elaborate on, in terms of, you picked a position within your field to best meet your needs and your abilities. And it sounds like Katie's had to do that as well. And Molly, is there anything you want to say to that?
Yeah, so I actually started out my career in the field with I went into private practice with my former LIND supervisor, who has been incredibly understanding. And I've had immense freedom to set my own schedule to determine how many clients I can take in a given week, how many notes I can get done, how much, like so much freedom that's allowed me to accommodate for my needs in a way that many folks don't get, and has made me incredibly grateful, but also angry in a way that others don't have the freedom to have their disabilities recognized and honored in the same way. Yeah.
I agree. We did have a question specifically for Diana about what personal qualities did you find helped to navigate your journey? I think part of it might be the transition to a faculty role. I don't want to like extrapolate though, so feel free to share your thoughts.
I think the quality that is well, I don't know if that's the quality that's helped me the most. I feel like one of my driving factors is getting angry about things. Like, I think that has been like one of the reasons I got interested in working with kids with disabilities in the first place is because as I was learning about development, I thought the development, all the different ways that brains could develop was really cool. At the same time, I would talk to, families and kids and realize they weren't getting the services that they needed or the support that they needed. And I would just get so pissed off about it. I was like, someone's got to do something. And somehow that led me into going into child neurology. So I think that the same kinds of things have really just kind of helped me figure out like where exactly it is that I want to be, even within the world of child neurology and what I want my career to look like. I don't think that I would have expected that I'm doing this much I guess, advocacy kinds of focused work. And I wouldn't be this comfortable with talking about disability and my own experiences if not for the fact that I started to hear that there were other people, particularly patients and people who came to see me, who had the same story that I did, who were having the same problems with access, who were having the same issues, whose doctors weren't listening to them, whatever. And they would tell me a story. I'm like, wow, that's happening to me. But they've talked about how doctors don't listen to them. And I felt like I have this, I feel like I'm in this weird position where on the one hand, I have the same history of doctors not listening to me. On the other hand, now I have an MD and a bunch of letters behind my name, and now doctors do listen to me. So I feel like one of the things that I've been able to do is, because I'm usually pretty shy and don't like talking about these things or myself or anything like that. But I've noticed that if I can tell a story to a physician and say, hey, I am a physician, let me tell you about my experience. Oh, by the way, my patients are having this exact same experience. Let's talk about how this is a systemic problem. These are systemic issues. Mm-hmm. Then I feel like that, I don't know if I would call it just getting angry or getting sticky about things or being really obnoxious. But I think that those are the things that have helped me kind of figure out where I need to be in terms of my career and the best thing that I can do in terms of helping out my patients.
Mm-hmm. Rebecca, I see the question that you have, but you touched on something, Diana, that the next question kind of connects to. And this question is, how can we best advocate to make systemic changes so that flexibility can be the norm, not the exception, especially in medical contexts? So anyone can feel free to share their thoughts with that one.
My answer is just be persistent on finding ways to express what not only you need as a person, but what you are able to advocate for those in your kind of sphere of experience. And that my way of doing that, because it really does feel overwhelming. I mean, that question to me is the one that feels like I have understood ableism at a higher level for 5 years and nothing has changed, and I haven't done anything to help that defeated personality. But then on the flip side, being here is part of my answer to that question, is that this is the sort of stuff that we keep kind of getting more and more traction. We have 59 people on this Zoom. I mean, that is amazing. So it's a great question though.
Yeah, sorry, words are hard sometimes. as Christopher was saying, they're absolutely sharing your stories. Stories are powerful and move people, but particularly when they're stories from people perceived as having power. So yeah, whether that's those extra letters behind your name or the position of influence you find yourself in as, you know, a teacher or, you know, whatever role you're in, particularly as a medical provider, though, being able to talk to your colleagues and peers and say, hey, this is going on and it's not okay, is beyond huge. As well as I found being honest and authentic with the folks that I'm working with, of saying like, yeah, I see that the system you're coming into is broken. Here's how I'm working to fix it. Here's how I'm experiencing it myself. I have found that allying with my clients to say, yeah, I am also neurodivergent. I also experience the world in these ways. Here's how we can work together to like combat the system that's against us, whether that be in the medical field or any other field. I've found beyond a powerful tool, as well as just being a person who's like, okay, so none of these systems were working, so I made my own. I stepped outside of this normal expected thing as much as I could. To still be able to practice in a legal setting, of course. But a lot of that takes not only courage, not only determination, but I come from a place, well, I don't come from, I am in a place of some financial privilege now. And I have the luxury to be able to I was able to make my own career and slowly build it, so to speak, that I know a lot of folks don't have. And so we're forced into roles. So I think one way to advocate for flexibility in the workforce is to say, is to also fight income disparities that are in the society.
So I'm sorry, I'm running my mouth. But I was just going to say, absolutely, totally echo what Molly is saying. And at the same time, yeah, don't be afraid to get creative with how you either advocate for yourself or someone else or for your community. One thing that I've learned with this whole kind of thing is that, you know, medicine is very, I don't even know what word to use, but it's very rigid about some stuff. And it's like, stories are really powerful, certainly, but the way that you tell stories and how you tell stories, you can tell the same story in lots of different ways. So maybe I might share, you know, my own experiences with doctors in one way, with patients in another, and with the general audience in a completely different one. Like at this point, I do a lot of writing, and some of it is academic, some of it is creative, some of it is opinion-based, but it all kind of has the same story, which is just that we're not doing enough to take care of disabled people. I'm going to use my story as a vehicle and then talk about my experiences as a clinician, as a patient, as a whatever, and then hope that whatever venue I'm writing in, like it's kind of a call to action for the reader. So if you want to write, if you're good with social media, get on social media. If you're the kind of person who can go and yell at some Congress people, do that. Just try to see if you can't figure out what your particular strengths are and just be creative about it.
I wanted to add something too. You know, just in keeping with a lot of systemic change, that's, you know, a lot of talk about systemic change and a lot of marginalized and minority, just minority groups that are going on right now. I just feel like disability is not being talked about within that conversation. And I just think that making sure that when those conversations are happening, that disability is being included, because it's at least the conversations that I'm at, it's not. And it's been frustrating. And, you know, talking about keeping it real, it's been, I feel like for me personally, I feel like I've been getting rejected as a minority amongst minorities. And, you know, even you know, I've been, you know, there was a report that came out that I read about a social justice task force, and it was 44 pages long, and the word disability was only used one time out of 44 pages. And it's like, we're not talking about diversity, equity, and inclusion then. It's just, you know, talking about race or gender or religion. And it's, you know, I just think that if we're going to talk about a lot of these systemic changes, which are all really good, I just think it's important to make sure that disability is not being excluded, because disability is the most inclusive minority group that there is. And, you know, to quote Senator Tammy Duckworth, like, and not to sound like a Debbie Downer, but like, we're all one day away from needing the ADA and needing accessibility and needing, you know, belonging to that minority group. And at some point in our lives, we're all gonna, you know, whether it's temporary or permanent, all gonna be part of it. And just to be, you know, to be aware of it and have it as part of our cultures, and be part of the conversation. I think is something that we all can take responsibility for. And I have found that so many healthcare providers are actually, in my experience, again, as a person in a wheelchair, the places that I am find the most microaggressions and macroaggressions and middle aggressions and all the aggressions, the places that I'm discriminated the most are in healthcare settings and the grocery store. They're the two places where people treat me the most ridiculous interactions are happen in healthcare settings and at the grocery store. I'm either an inspiration for buying a loaf of bread, and I'm like, thank you. Or I'm not capable of pushing myself up in line at the store, and someone comes up and like literally pushes me. I'm like, are you stealing me? Like, what's going on here? Or like some sort of nurse comes out into, you know, nursing assistant comes out in the waiting room and just like automatically starts pushing me. And I'm like, I'm sorry, I can push myself. And like, well, most people appreciate me pushing them. And I'm like, whoa, let's calm down and let's have a discussion about this. And just like, don't make me go Jersey on you, you know? And it's like, you know, when I went and got my COVID shot, the nurse practitioner who did it, like bent down and put her hands on her knees and was like, look at you. And I was like, I am 39 years old with a doctorate degree. Oh my God, what is happening now? Like, I am short circuiting. Like, I literally was like, am I going to get a lollipop out of this situation? I didn't, which really irritated me that I had to go through that sort of like dehumanization and didn't even get a freaking lollipop. But that's about how old I felt, the way she was treating me. And so healthcare providers, if I'm being honest, I love us, but we need to do a better job. And so all that was to say tangentially, which my students know I tend to do, we need to talk about diversity, equity, and inclusion, and it needs to include disability, and healthcare providers need to be open-minded about it and realize that they don't know about it just because they're healthcare experts. I'm going to stop talking now. Thank you.
Thanks for sharing, Katie, and adding humor into all of your tidbits that you share. Christopher, do you have anything you want to say?
I was just gonna follow up on Katie's great thought, which is that I've spent a lot of time trying to help people understand how disability represents diversity and that disability is diversity. And Katie, I like that you said about not being a Debbie Downer. The way I've tried to explain it to people is that disability is a part of the human existence, a human experience, the range of experiences. And whether or not you consider just a disability to be very elderly, at some point you would be, if you have a long life, you would experience it. And I try to help people see it that way instead of something could happen to you tomorrow, because that's where the ableism pops up and the fear and the like, oh, I you know, this sense of Olympic athletes that would rather be dead than have a disability. That there's a study that shows that. And that's all the ableism speaking. And then for the ways to try to get this effort, I have total imposter syndrome with trying to talk about disability as diversity because I'm a white male. I have all the other privileges you can imagine. And then I keep realizing that's exactly why I should say it, because it brings out, again, my intersectional experiences and I become a better ally for it. And so I encourage anyone here, when you're thinking about when you go to be a student somewhere or you're a faculty someday, that when you think about your diversity, equity, inclusion offices of any place that you're at, really be vocal that you, if they're not already including disability under their purview, that they do. And here at Duke, we actually don't. I'm the most vocal person continuing to talk to them about how do we be, you know, it's not diversity, equity, inclusion office and the accommodations office. There needs to be a disability part of the strategic plan that in our diversity office that's not there yet. I've only been here since 2019, but they have a lot of emails from me. So that's the kind of thing that you can do.
Yeah. Thank you for sharing. And I see a lot of material in the chat, so I will do my best to address everyone's question. I'm gonna jump back a bit to a question from Rebecca Brown. What are your thoughts on disclosing in a professional setting with patients, specifically if you have an invisible disability?
I can talk a little bit about that. I'm sorry, I feel like I keep jumping in, but this is a very exciting panel because I actually disclosed to a patient today, which is why I guess this is fresh in my mind. And I also wrote an essay about this not too long ago. If anyone, I don't know if we can plug ourselves, but whatever.
Feel free to put it in the chat, yeah.
If you want to read some more about my thoughts about disclosure and disability, at least in medicine. So I think disclosure, especially if you've got an invisible disability, you know, and disclosure just in general is always very personal. And I think that a lot of times when we have these kinds of panel discussions, that's one of the questions that always comes up, like, when do you disclose? Do you always disclose? Do you tell everybody? And, you know, no, I don't always tell people that I have a disability. I think I'm at the point now in terms of my physical symptoms that I can kind of pass for non-disabled most of the time. I know that I always get sideways looks from doctors, and you know, anybody working in healthcare, I think they can pick up on some of my kind of issues with the way that I hold my hand and the way that I walk. But if you're just kind of looking at me from afar, you might not necessarily notice. So some patients come into the clinic, I don't necessarily tell them, they don't necessarily know, but there are some times when I feel, more times than others, like I should disclose, just so that the patient kind of understands that not only am I telling you that I'm trying to help you from a perspective of being your clinician, I'm also trying to help you as a member of your community. Like, I understand what it is that you're going through. These days, more so than anybody, it tends to be patients with migraine and chronic pain, because so many of those patients have this history of doctors or people in their family not believing that they're in pain, not believing that it's serious, not believing that it's something that can be life-changing. So a lot of the times for those particular patients, I'll be like, listen, you know what? I'm trying to talk to you about this migraine stuff because I understand, I get it. I know that this hurts. I know this is serious, and I know that people don't treat it like it's serious. So I want you to know that I'm here with you on that professional level, but on a personal level too. The patient that I actually met today is another stroke survivor. And the reason I found myself disclosing to that person was partially, sorry, my little notifications are going off, partially because his mom was kind of looking at me because we kind of hold our hands in the same kind of a way. So I think she was picking up on some things. And also because this patient seemed very, very nervous and distrustful of doctors. And again, it was the same thing. I was like, look, I'm telling you this because they were struggling with some of the things that I was trying to do as part of the exam. And I just kind of shared with them, like, listen, I'm doing my exam this way because I can only use this side of my body. Let me show you some of the things that I've learned to do to be able to do this kind of thing. And whereas normally I might do some of my testing with one hand, I kind of showed him what it looks like with both so that he could see that I have trouble on different sides too. So that again, he can kind of see that it's not just about lip service here. So I think for anybody, disclosure is going to be, you know, personal. I think disclosure always comes with a risk. Particularly in medicine, I know that there are going to be some things that I feel more comfortable about talking about. That's my physical disabilities, as opposed to like anxiety and PTSD symptoms and things like that that I have, because those are a lot more stigmatized and also can come with professional risks like licensure issues and question of fitness and things of that nature. And I can also say, again, I'm in a really privileged position now so that I can be protected, you know, if I choose to disclose, which I wasn't always in this position. So there's a lot of different things that you kind of have to navigate and figure out how safe you are and when there's that safety is involved.
Thanks for sharing. Molly?
Yeah, I have, sorry, trying to transition to my thoughts because I was listening so intently there. Thank you for sharing that. That was, yeah, great. Really, when I choose to disclose has changed over time. I stuck hard and fast to the rule I was taught in school of like, you use self-disclosure or any kind of any kind of self-disclosure, whether it's disability or anything about your personal life as a psychotherapist, only when it's like there to benefit the client. And through practice experience, I found more and more that by not openly disclosing, even from like my website, saying like, yeah, I'm neurodivergent, was doing a disservice to many of my clients because they felt a lot of them seemed to feel that coming in, they had to explain themselves to me. And when I would disclose, it was an immediate shift to like, oh yeah, you get it. Oh yeah, like you might not get every aspect of this, you might not experience it in the exact same way, but you have like lived experience with this. So I don't have to explain what a like sensory sensitivity is. I don't have to explain these small details. And when I put that on my website, I've had so many folks who are like, I sought you out because you like said you had this identity and I needed someone who would get it. So it has been really, really powerful to be kind of really authentic from the beginning with my clients of saying, yeah, I get it. And also has enabled me to model self-care to when I get migraines, to say like, send out an email saying like, hey, I am so sorry I have to reschedule today's session. I know this can be a challenge. I have a migraine and I have to care for myself in that. And when I'm encouraging my clients all the time to care for themselves and to value their own needs, if I'm not doing that and I'm trying to like sit there and be present when I like completely distracted by, you know, very, very intense pain where I would rather be off sleeping or vomiting, then I can't be effective as a clinician. And within that, there is and has been that fear of like, what if the board decides that like, that disqualifies me from being a therapist? What if someone complains that not knowing me or makes some assumption, what if? And I eventually decided that, well, there's like almost no qualifications to be a life coach, so I could always just switch to that. But not everyone has that flexibility in their field. So knowing what you can do and where you have the freedom to push bounds, I think is highly, highly important to saying, where can I push? Where can I think if somebody asked, where can I rock the boat and push without endangering my own livelihood, without endangering my licensure? It's a hard battle to figure out. Hard, yeah, really challenging.
And I just wanted to add about the rock the boat question. I had responded. You know, I think that the most important thing that students can do is, you know, for students at UNC, we are very lucky. We have an incredible disability services office, ARS. They are super understaffed and under-resourced. So I know that they are super swamped, and you know, there's a lot of advocating going on for getting them more resources, but the people who do work there, they know their stuff and they know the law, and they're very making sure that like students, you know, do have their rights being met, but making sure that students have their rights being met and their accommodations being met, having conversations with your clinical education coordinator, having conversations with your professor, and like learning the strategies for advocating for yourself. And then if there's something called the interactive process that should be happening between your clinical education coordinator and the disability services office and your clinical education site. And so if you're asking for reasonable accommodation, for example, to have a service animal at your site and your site says no, they can't just flat out say no. They have to say why. because there's no reason there. I mean, it is almost impossible for any site to deny someone with a service animal, I'm just using that as an example, from having a service animal as part of their clinical rotation, unless they're doing a rotation literally in an operating room or like a burn unit or something, where there would be some sort of like, like air, the dog can't be, put in bubble wrap kind of thing. Like there's no place that a service animal cannot go. So someone having allergies, fear of dogs, like, oh, we're not comfortable with that. Like, no. And that has to be an interactive process that goes between your clinical education coordinator, your student disability services office. And so as a student, you can advocate to rock the boat for change through your university within your program to those sites. And so to answer your question, Lacey, we have a great program, so you can tell us what you need, and like, we've got you, and we are rocking the boats. I was on the rowing team, so I am rowing smoothly, but where the boat is moving. But for students who may not have a strong disability services program, that is a great way then, saying like what you need and making sure that the programs are getting built up so that your school can be rocking the boat on your behalf, rocking the profession on your behalf, one site at a time, which I feel like there's a bumper sticker in there somewhere, or a t-shirt, clinical education coordinators, changing the profession one clinical site at a time. We're going to do that. But I think, that protects you, and it also empowers students who are going to come behind you. But all of you as for students, like, you have a legal right to these accommodations. And so making sure that you have a strong system in place, and also learning how to empower yourself and learning these accommodations now as students, because once you leave, my office, I can't help you. And I'm saying that as me, because I'm not your fieldwork coordinator right now, but like, once you leave school, we can't help you anymore. Like, you are on your own to figure out these systems. And so taking advantage of how to figure out reasonable accommodations, what to ask for, what the laws are, so learning to empower yourself and learning how to rock your own boat, and learning what the laws are and what your rights are really, really important, so that when you do graduate, you can say, if you have a service animal, like, no, I have a right to have a service animal, and you go through the interactive process and you know what that process is. So that is my advice to you, Lacey. But we'll talk in my office on March 21st at 4:30.
Thank you all for sharing your perspectives and for sharing all that you just shared, Katie. I will do my best to address all the questions in the chat and see those that have already been answered. But if we do not get to everyone's question tonight, I ask that if you're comfortable to have the panelists put their email in the chat so that you can reach out to them afterwards. But I do have a question here that was originally directed towards Molly, but I think could be answered by any of you. And that's, when you graduated and started working, did you think of issues that occurred in the program in relation to your identities that you hadn't been able to think about until you graduated? And this is by Lydia. I'm not sure if you already answered it in the chat, Molly, so feel free to say so if you did.
There we go. Took me a second to unmute. Yes, no, absolutely. The number of things that I recognized only after I'd had the time and mental capacity to process everything that happened at grad school, and unpack my own internalized ableism in many ways, was when I saw, oh, that's a lot of problematic things that happened. And I don't think anyone had negative intentions, but even going up to professors saying like, hey, I'm actually really stressed about this paper and getting it done. And was always met with like, I know you'll do fine. Like, don't worry about it too much. Just like, thanks, I understand my grade will be fine when I get it done. My issue is actually having the executive functioning present to finish a paper by your deadline in the midst of migraines and chronic pain. And that component of it was never seen. And it wasn't something that I was ever able to articulate in the moment, because I was just so taken aback by like, why does this reassurance feel so wrong? And it was absolutely met with the best of intentions, and it didn't acknowledge my experiences as a disabled individual.
I'm sorry that happened, Molly. Thanks for sharing your perspective on it. I'll wait a few seconds to see if any other panelists want to chip in. If not, I will move on to the next question. Okay. This one might be more directed towards Diana and Christopher, but one participant asked if there's anything that can be done for people who have looks to be chronic disabilities and needing lots of sleep. This question was by Jeremy Fine. So I'll just read the whole thing because I don't want to miss anything. But following discussion on sleep and getting 8 hours of sleep a night as a critical component in the lives of many individuals, like for them, living with chronic mental health conditions or other neurodivergencies, as is having time for exercise and therapy. The technical standards of many residency programs don't allow for a lifestyle that has enough time for well-being, with the norm often being very long hours at the expense of time to oneself. So what can be done in terms of those disabilities, or can those with those disabilities simply not thrive in such residency programs?
You want to go first or me?
You go first, I'll go second.
Yeah, it's a hard answer because it's one of those things where you can imagine idealistically a world where doctors don't need to do this to themselves. That world is several steps away because it's multi-layered. We have ableism, we have a very strong problem of capitalism in our healthcare system, because the reason residency is so hard is that our hospital systems would crumble without residents being worked to the bone across the nation. We are so overly dependent on those hours that we don't know how to get out of it, because once you're a faculty member, you're not supposed to have to do all that stuff. But when you look at how the UK has their medical system set up, it's a much longer residency, but it's much more palatable to all the things that Jeremy is asking. Reasonably, can a human being have? And so the answer is not great, except for don't give up. I go to this sense of, if it's your passion and it's what you want, you just have to be very vocal, and you have to look for the programs that are going to understand, because of some of the things we already talked about, and they're working against that grain, but it is a grain.
Yeah, I absolutely agree. I would say, like, certainly if you want to be a doctor, be a doctor. Goodness knows we need more disabled doctors, like, everywhere in every specialty. But I think one thing, you know, as I've been working with more disabled pre-meds, one thing that we've been talking about a lot is your fit within a specialty, and what realistically is going to be the right specialty for you. On the one hand, if you're someone who wants to be a cardiothoracic surgeon, I want to cheer you on and say, keep going. At the same time, I recognize, like, if you're a person who has a lot of issues with fatigue, or you're a person who really needs a certain level of sleep because of either mental health or because of, you know, physical stuff, or you have epilepsy or something like that and really need your sleep, it might be hard to be in certain specialties. I think that I feel really good about the fact that I went into pediatrics, where things are a little bit more, I don't know a good word for it, but I think in peds, we're a little bit more aware of some lifestyle stuff than some specialties are. And at least my attendings would ask me if I'd eaten. If nothing else, I wanted to make sure that I was fed and hydrated, even if I wasn't getting sleep. And I know that, you know, the workload, even though it was rough, was nowhere near like some of my friends from med school who went into like surgical specialties and things like that. So there are going to be certain specialties, I think, which one have a better work-life balance, whatever that means, and 2, have less demands on residents. But that doesn't mean it's going to be easy. So I think another thing that you can do, in addition to making yourself very familiar with the disability services and accommodations that any potential residency program would be able to provide, is look at the culture of the program that you're interested in and see if that would be a good fit for you as well. Is this a place that has other residents with disabilities who are open about their experiences, or faculty with disabilities who are open about their experiences? I think that's also a good sign as to whether or not you might be a good fit there. Because at least that means that there's somebody thinking about these issues and trying to work on this kind of stuff without it being a trial by fire when you get there. I would also say, like, is this a situation where you're going to be the only resident, so you're expected to do everything? Or is there like a group of people so that maybe if you're having like a high pain day, there's somebody else who can kind of pick up for you and you pick up for them at a different time? So I think, you know, there are going to be different things that you can look at a potential program and see if it might be a good fit for you, but really thinking about specialty, I think is also going to be important when you're thinking about how much you're going to be able to do and how much work you're going to have to do on any given day.
Thank you both for sharing that. And I think, oh, go ahead, Jeremy, did you want to chime in?
Well, I just wanted to say thank you. I appreciate it. Luckily, I want to go into psych, which tends to have a pretty understanding lifestyle. But I would like to think if I wanted to be a neurosurgeon, I would be able to as well, and still be able to enjoy my life at the same time. But I really appreciate your thoughtful answers. Thank you very much.
Yeah, I will say that I wanted to do surgery, and it wasn't because of my disability that I didn't. It was because of the system and knowing that I can't have all that I want out of life to do that.
I will go ahead and move on to probably close to our last question, or a few questions given the time. It is, what do you think the need for increased flexibility caused by the pandemic has taught us about accommodating people with disabilities?
I'll go based not only on my own experience, but also hearing from my clients that it's really showed up that we can absolutely accommodate things that people were told for years we couldn't, like working from home, having a flexible work schedule, all these things that as soon as everyone needed them, it was, oh yeah, of course we can make this work. But before that, it was, oh, you absolutely won't be able to fit into our program, or there's no way we can, you know, have you present or do things via telehealth. And yet there's so many more flexibilities that I've seen people make because of the pandemic that I'm really hoping sticks around more, and that we don't just like jump back into business the way things were done before.
That's a good point. Hearing, oh, go ahead, Katie.
I was gonna say, I just think it's made it more possible. I had surgery in January 2020, and I personally was back to work sooner than I had anticipated, and I think it just made things more accessible. I have friends who have a son who has congenital heart disease, and you know, he was able to go to the zoo for the first time on Zoom, because the zoo had Zoom. There was a lot of zoo going on there, but you know, wow, it's been a really long day. It's my second panel of the day, and I had class this morning. The zoo was Zooming, and so he was able to like experience things. And so I think for me, the pandemic has really just opened up so many more possibilities about what is possible for accommodations and people with disabilities, and I hope we don't lose that.
Yeah, I totally agree. There's so much that I feel like I've been able to do, and so many ways I've been able to connect with patients that I wasn't able to before. You know, I work with a lot of patients that it might be really hard for them to be able to get into the doctor's office or to take a long trip to come to see me. So being able to see them in their house where they're feeling comfortable, they've got like everything that they need for support around them has just been really wonderful. At the same time, I think that the pandemic has also revealed a lot of inequities in certain areas. And I'm really hoping that in addition to keeping all of this accessibility, this brand new, brand new ways of accessing people, that we also recognize that there are still these inequities with related to, like, patients who don't have access to Wi-Fi, patients who don't have access to even the equipment like a computer or a phone that's going to be able to connect them with the internet, people who live in rural areas, people who have, limited access from other means. So I'm hoping that, yes, we keep everything that it is that we've been able to develop over the last 2 years, but also recognize that there are still people having trouble, and we try to figure out how to help the people that need the most help.
Thank you all for sharing. I will move on to the last question and then we'll wrap up. So maybe if just one or two of you want to answer this one. What are your relationships like with colleagues at work, and has it been difficult to be promoted in the workplace because of your disability? I know we kind of touched on that a little bit, it sounds like, and Diana, you did, I think, if I'm remembering correctly, some of them are, I remember one thing you mentioned, that they're kind of too cautious of you now and want to protect you.
Yeah, I mean, not all of them. It's just that some of them, I think, because they spend so much time working with patients who've had a stroke, they're like, oh, I need to make sure that you're okay at every single minute. And I'm like, I'm good. I promise you, I'm going to be okay. I don't know, about the promotion piece yet, because I need to start preparing my package for my mid-cycle review, which I am not looking forward to. But I will say that, the longer I've been here, the more disability stuff that I've been doing, the more that has been my focus. And I initially thought that I would not get as much support from my department as I do, but everybody's super excited about it, which is on the one hand good, on the other hand incredibly surprising, because that's not usually the response that I get when I talk to doctors about disability and specifically say, we're terrible at this and we need to do better. Usually people just kind of get mad, but they're like, yeah, we're terrible at this, let's do better. So that's nice. So we'll see if that translates to promotion. I don't know yet.
Well, thanks for sharing. Would anyone like to share any final comments, last pieces of advice or wisdom before we close out the panel?
I was just gonna say, for all of the Debbie Downer moments, and for my own Debbie Downer moments, for mine, where it's like that big mountain, have mercy on yourself for the time when you feel overwhelmed. That is the number one thing, because if the old Calvin comic, some days even my superhero underpants don't help, and that's okay. You'll wake up the next day with the pants back on and they help. So that's my final point.
I like
Yeah,
it.
I don't have, I need to get I don't have cool underpants like that. I don't know why I just shared that with my entire class, but it's late. I just want to share that it's okay to have feelings and grief and be sad, and just realize that what you thought your career would look like may not look exactly what you thought it would look like, and it might take time to process that, and be frustrated and pissed off, which I don't know if I can say because I think my boss is on this call. Sorry, Nancy. But I went to a public school growing up, but it sucks sometimes, and that doesn't mean that there's not a space for you. It doesn't mean you're not going to be a phenomenal healthcare provider. I went to Ghana, Africa, and I made a little girl with no hands a splint using a toilet paper tube and duct tape. So I know I'm a badass OT, but I also know that it is not safe for me to work in the ICU with people with unstable cervical neck injuries, and so it's okay. And it took me some time to process that. And it doesn't mean that I'm any less of an OT than anyone else, but take some time, process it, make sure you learn about reasonable accommodations and the ADA law, because those are your civil right just as much as voting, paying taxes, and all the other things that we get to do as Americans, and take advantage of those and know them better than anyone else, because they're your gift and they're your tool, and people fought for you to have them. So use them to empower yourself, and email me if you're not sure about them. I'm happy to help you with more information. That's all. Thank you.
Thanks, Katie. Molly or Diana, any last words? I feel like everyone shared great information throughout. So, well, thank you all for joining us tonight for the panel. I know we're a minute off schedule, but yay, it's only a minute. Thank you to our panelists for sharing your personal experiences, and we hope that this event will serve as a catalyst to create inclusive educational and employment opportunities for individuals with disabilities in the future.